March 24th, Hayek Medical was made aware of a patient who had been receiving continuous ECMO treatment in the excess of 100 days. The patient's critical care team had tried nearly every possible strategy to allow their patient's lung to support them without the ECMO unit. They were eager to see their patient advance from the need for this highly invasive form of support.
The Hayek clinical team was contacted to determine if there could be a potential for BCV to help with weaning their patients from ECMO.
All right, Dr. Bartok, thank you very much. It's very good to meet you. I heard you've had some experience with the RTX with a patient. Would you be willing to give us some non-patient identifiable information about the case and how you came to use the device?
Sure. So we met a 40-year-old female, pretty complex medical history. She had a history of systemic lupus erythematosus, pretty severe sort of extra-articular manifestations, with lupus erythematosus. And she also had a form of autoimmune pseudo-obstruction of her GI tract that left her PEG and TPN dependent. And she has a common variable immunodeficiency, for which she was on immunomodulators, and a complex family history of HLH with a sister requiring a bone marrow transplant. So she came in pretty diseased. Now the main part of this is that she was being supported with TPN because they could no longer use her gut. Now, I paint a picture of a chronically ill 40-year-old woman, but she was very much independent. She was a teacher and actually went out on disability due to the TPN dependence about 6 years ago, but very much was sort of, the rock of her house. She didn't have any children. She cared for her nieces. So otherwise pretty healthy despite these serious chronic diseases. And she was receiving intravenous anakinra for this underlying inflammatory disease that she had. And she developed a complication of bacterial endocarditis from a PICC line infection. And she was initially admitted here at Cooper at the end of November for bacterial endocarditis with septic emboli to both the lungs. And then the endocarditis was both left-sided and right-sided, involving the mitral valve with secondary emboli to the brain. In the setting of this MSSA endocarditis, she developed severe ARDS at the end of November, very beginning of December. So we met her in our intensive care unit in December with severe ARDS, basic, ARDS best practices, including prone positioning. And then she was continuing to progress in the face of what was probably secondary HLH due to this infection, which made her lung injury particularly severe. And we made a decision to place her on veno-venous ECMO. So we supported her on VV ECMO for about 100 days. And, she was able to wake up. She was able to participate in physical therapy. She followed commands. She did all of the things that we would want for her from a VV ECMO standpoint. However, she still remained very much dependent on the ECMO membrane lung for ventilation. Surprisingly, she had severe hypoxemia, refractory hypoxemia, requiring pretty high ECMO support. And she recovered sort of that hypoxic reserve, but she was still not able to ventilate. And, it was a combination of very low, what we thought was initially was just low lung compliance, with tidal volumes on safe pressure control settings of only around 80 to 90 cc's. And despite our best efforts to work with her to get strength and mobility and provide as much time as possible for innate lung healing, she never regained her innate ability to ventilate. And throughout this process, she would get very tachypnic. Changing different modes of positive pressure ventilation were troublesome. The tachypnea led to bilateral apical pneumothoraces, and which had to be supported. And it just was really hard for her, probably due to a high amount of mechanical strain, secondary inflammation, and some what looked like primarily apical lung fibrosis. prevented us from really being able to get much more out of the positive pressure strategy. And it left us in a place where she was, dependent on the ECMO membrane lung for CO2 clearance. And I think you can imagine when, from a VV ECMO support standpoint, 100 days is a case report in and of itself. I mean, you can look into the literature for solitary, lung support for patients on VV ECMO, probably sitting in that 100 to 120 day time frame for prolonged ECMO. Prolonged ECMO actually for lung support is defined as greater than 14 days, and we're talking 100 days of ECMO support. And due to her TPN dependence, although she didn't have any other absolute contraindications for transplant, the TPN dependence due to her intestinal pseudoobstruction took her off the transplant list. And we had talked to every institution, both in New Jersey and Pennsylvania, as well as New York, and all of our friends, in transplant, but we couldn't get her a new set of lungs. So we were honestly left in a place of likely having to kind of decide on, institutional driven removal of ECMO support, because, can't keep her on ECMO forever. And honestly, the membrane lung although is great, has a ton of, long-term effects, complications, troubleshooting. And she was starting to really develop a lot of those complications, specifically hemolysis. And I know we're not here to talk about ECMO, but we were getting in a place where prolonged ECMO was proving difficult to maintain, frequent circuit changes, a lot of hemolysis, things that were all very detrimental and would probably innately kill her over time if left on ECMO. Or if we could try to get the most out of what we were left with from a lung mechanics standpoint to see if we could wean and provide better ventilation. The interesting thing about her is when you look at her, what she was able to generate, and honestly, we tried every single mode of mechanical ventilation that we could, and the only one that she was relatively synchronous and could tolerate, without having to deeply sedate or paralyze her, was pressure control. And, her innate inability to ventilate, that baseline, what appeared to be more dead space ventilation than anything else. If you looked at her CAT scan, she had pretty decent apical lung scarring. But outside of that, both, the remainder of the lung looked certainly viable, much better than some of the interstitial lung disease patients and whatnot that I've seen previously. So it was a little bit unclear to us why we couldn't get more out of her minute ventilation, and why, despite our best efforts with positive pressure, we weren't able to generate larger tidal volumes, because it didn't all seem like a lack of lung compliance. So the thought process behind that was, that we probably, due to her ARDS, she had a high degree of ventilatory redistribution. There was certainly some pretty severe truncal instability and muscle weakness. And you could see that when she would participate in physical therapy. Her extremity strength was getting better, but, prolonged critical illness, her difficult to manage nutritional needs in the setting of prolonged critical illness, and certainly, the high degree of steroids and everything else she had been exposed to due to this underlying secondary HLH in the presence of an autoimmune disease and pretty significant infection, I think led to a lot of musculoskeletal weakness, particularly truncal instability. So she had some limitations in her functional residual capacity, her ability to utilize, her intercostal muscles for strength and to drive, some of that ability to expand the chest wall. And then, I think apex to base, she had some significant, issues with ventilatory redistribution. I think if we all look at like kind of post-mortem ARDS lungs, you can really see there's areas of hyperinflation, areas of, alveolar collapse, and the whole ventilatory redistribution can be really difficult to get, sort of uniform. And I think that we weren't really able to drive tidal volume or impact, especially those lower lung fields that were otherwise, looked very much viable on CAT scan. So then, the thought process was, well, do we give her a shot with an additional mechanical assist to come off of ECMO and breathe for herself? And I think that's where the idea of using a negative pressure assist to be able to offset some of that work of breathing, to be able to provide her with, with additional strength to, increase the AP diameter of her chest and to increase her functional residual capacity. And then in that, maybe we get a little bit of recruitment for areas that are recruitable, or maybe we better redistribute ventilation apex to base and start to work with those areas of the lungs that we felt weren't being touched. And this high degree of dead space ventilation felt like it was potentially reversible. So that was where the idea of using a negative pressure assist for somebody on positive pressure ventilation came in to wean ECMO. Which, as far as I can tell, has not been done in the literature.
That was an excellent summary. And indeed, your rationale for utilizing the BCV is exactly our intention for its effect and how it is designed by enhancing diaphragmatic excursion, by enhancing the ease of chest wall expansion without adding any barotrauma. Which we cannot avoid when we're using the positive pressure techniques. So would you say that, it sounds like you went through all the natural processes for weaning from ECMO that she was recalcitrant to, that the normal techniques you would use were not successful?
Absolutely. Yeah, without a doubt, from aggressive focus, highly focused, sort of, almost, couture, support from our ECMO team and our residents, to make sure that she got additional PTOT time, bedside time, nutritional support, trialing multiple modes of mechanical ventilation to see if we could provide any additional recruitment, changing the tracheostomy, to seeing if there was any, additive resistance from the trach position that allowed us, that prevented us from reaching our maximum inflation potential on a pressure control mode of mechanical ventilation. All of those things were done over and over and over again. And, we reached a point that, every ECMO team reaches is where, we don't, it's you come to an area where it can be a bridge to nowhere because we can't offer lung transplantation and she can't survive without the ECMO membrane lung. And, I think for prolonged ECMO, one of the things that recover quickly is, I shouldn't say quickly, one of the things that tends to recover first is the hypoxemia and the oxygen reserve. And then the ability to ventilate tends to lag behind. And that's one of the things that's a poor prognostic sign, in prolonged ECMO. Is this high degree of what usually accounts for dead space ventilation, which oftentimes is due to lung fibrosis. I think in this particular case, there seem to be areas of viable lung that, even in our patients with interstitial fibrosis seem to do just fine in ventilating. And, it was almost more of a restrictive pattern with her and, and a low FRC that may have been preventing us to maximize the use of those alveoli over the ones that were damaged. So I think there was tremendous discussion, chalkboard, and looking at other opportunities through chalkboard logic, even the utilization of things like heliox to reduce resistance to see if we could get a better opportunity, to ventilate areas of the lungs that didn't prove fruitful initially. So I think we looked at everything, and then like every ECMO program, you reach that place where you've done all that you can, and you have to make a decision to potentially remove support or continue, knowing that it's all a matter of time where the patient either succumbs to their disease process, an ECMO or an ECMO related complication. And, it made it very difficult for someone who was awake, could look at you, to clamp and come off ECMO. So I'm still emotional because we spent a lot of time with that family. So
understandable. God bless you, sir. It's it takes not just know-how, but it takes a lot of heart to be able to bring somebody through that and go through that with them. So my condolences to you, and of course to the family, but also my praise for your support of them and your efforts. Now, so having not responded as typical, as we would expect, ECMO is there just as a time frame, a time hold to allow the whatever processes to heal, to not offend the pulmonary circulation and the pulmonary tissue, and allow that healing to happen so that they can resume normal respiration. That didn't happen for processes that were specific to this patient. But once you had the idea to use BCV and it was available to you, do you recall how you made that intervention first? Like what sort of settings you tried, or what sort of response did you see when you first used the device?
And certainly, I mean, and everything was in collaboration with your team, and I'm absolutely so grateful for the responsiveness and being able to bring an educator, because I think from my standpoint, it's very easy for me to suggest something like bringing in a new device, and trialing something, but I have an entire respiratory care team who is on the hook for how to operate this device. And, you can imagine that it was very, it was, I don't want to say scary, but it was, it was certainly nerve wracking for our team to have to learn, and educate on the fly. And I think you guys were excellent for that. We looked at, at probably the best, means to do what we needed was to provide, continuous negative pressure support, and allow her to breathe spontaneously on positive pressure. And, we started low, at -10, and to see how, if there was any improvement. And I think for your standpoint, it's always hard from a chalkboard logic standpoint. We, trying to think about, barotrauma and, and the impact on, transpulmonary pressure. If I'm adding a negative pressure assist to somebody who's also breathing positive pressure, it's very hard for me to argue safety and feasibility if I don't have like continuous esophageal pressure manometry. I will say, there was no, if anything, the difficult to recover residual left apical pneumo that she had actually improved, and starting low and titrating up for comfort was what we did. I think we settled on a max of -20. For our continuous negative pressure assist, and sort of sat back to see, if there was any impact in her tidal volumes. And certainly we saw a change in her minute ventilation almost immediately after applying the device.
Was the patient able to relate any sense of how it affected her?
I mean, she was, alert, and never complained of discomfort. She had a very attentive family, a very attentive mother. So I think that every effort was made to get insight into any discomfort. And I think I don't recall her ever having issues with comfort, certainly not with fit or skin breakdown, able to apply it over over her hospital gown. And to apply it, with a persistent left apical chest tube in place, pigtail catheter, without any issues. So I think for fit and comfort, there was no problem.
That is very good to hear. And and I think that this did indeed affect her positively over time, the time period, and she was able to transition from ECMO at some point?
Yeah, within about 72 hours, we were at a place where her minute ventilation allowed us to completely wean off the sweep gas flow, which is, what we use to remove carbon dioxide via the ECMO membrane lung. So you could see, when we started, she would have, on pressure control of what initially was 23/5. she had tidal volumes in the 80 to maybe 120 milliliter range. And by the time we titrated up on the CNEP to -20, she was probably sitting in the 230 to 290 on average tidal volume range, which for her, she was very small. So for her, sort of kept her in that 6 cc per kilo range, and was able to almost double her minute ventilation. And she was able to wean ECMO support in about 72 hours.
That's marvelous to hear from that perspective at that point. And can you think of how, is there a specific mechanism you feel that was the most effective, that what was specifically corrected in that?
Yeah, I do. I think it was a combination of all three. It's hard for me to say entirely. I do think that the negative pressure assist for her intercostal weakness allowed to take over that work and allow an increase in AP chest diameter and pull more volume. There was without a doubt lung recruitability there. And you could see it, when you removed that support device, and she wasn't able to exert that effort, including, probably pulling in more of her FRC and getting the most out of those lower lobes, without a doubt. And then I think, with all those things, an overall increase in recruitment, increase in FRC, and offsetting some of that work of breathing, or what really was muscular assist at that point, allowed her to pull a larger tidal volume at a set pressure. So, I think that those three things prove that dead space fraction was reversible and not attributed only to low lung compliance from pulmonary fibrosis in the setting of refractory prolonged ARDS, which I think most of us would attribute her lack of minute ventilation to, previous to this. Yeah.
Excellent. Can you think of, a reason why this intervention might have been more successful than the very extensive manipulations you did with the positive pressure ventilation?
I think
that
intervention. Yeah.
Go ahead.
I think it was tailored to the patient, and to those patient needs. Now, every one of our ARDS patients will have, certainly different reasons for, a lack of reversibility. I wish that, prolonged ECMO was enough to guarantee either, lung healing, or some potential lung regeneration. That is what we're doing. There is no therapeutic benefit. It's just providing support and time for the lungs to heal when you would otherwise never be afforded that time on positive pressure ARDS best practices alone, and remains, an off-label use, So I think that we were able to tailor it to the patient. And I think in these prolonged runs, we have to take a look at what the patient's able to do mechanically and what they're able, and how that correlates. We tend not to rely too much on what we see radiographically in ARDS care, because very often, the CAT scan might look atrocious and their lung compliance is not bad, and their VQ match is otherwise, pretty good, and then in situations like this, you're very surprised that, she has very minimal oxygen requirement, 30-40%. The lungs are inflated, and there seems to be some, mechanical means why she can't, clear carbon dioxide. Is that a disease of the alveolar, capillary interface? Is this really, fibrosis and, post fibroproliferative ARDS, and this is non-reversible, or is this a function of her not being able to generate enough of a tidal volume, bypass these high peak airway pressures, and be able to support herself, long enough? Because there were moments during this prolonged run where she got down to very minimal sweep, but fatigued and regressed backwards, right? Mm-hmm. So having the amount of reserve that you would want to see in someone, she never got to a point of being ready for discontinuation of ECMO. But during this, this latter 60 days of her stay, on ECMO, we got to places where we got on lower support, but never had the reserve where you could feel confident that if I discontinued ECMO, she could fly on her own.
Mhm.
So, really, like for all the things that we do, using the ventilator to take over some or all of the work of breathing, then using ECMO to take over some or all of the work of what we can't do in the native lung, looking for an additional mechanical assist that isn't, invasive and doesn't have the complications that the ECMO had, was what I think was beneficial in her particular case. And we were able to tailor that for her. So something like this, providing additional mechanical assist, taking over the work of that residual ECMO membrane lung, because we felt that she had reserve in her. And a lot of it was attributed to muscle weakness, lack of diaphragmatic excursion, and probably, unequal ventilatory distribution, apex to base. That this particular device, I think, hits every single one of those potential reversible causes. And you could not do that with positive pressure ventilation without potentially finding yourself in an uncomfortable situation, or like you said, being at risk for an increased barotrauma, or certainly increased mechanical power over time. And then, similarly, staying on ECMO indefinitely is never an option, and you will succumb to something, as it relates to complication from the ECMO patient interface.
Indeed. Well, again, sir, I can't say enough praise in how your vision for reaching out to trying everything to help your patient. And it is obvious that you are a true caregiver, and the outcome of your patient is your ultimate goal. And God bless you for that.
Yeah.
And I can tell you that. Go ahead, Gary. I'm sorry.
Just real quickly, Dr. Bartok, this is probably, as far as we know, the first use to wean or to bridge a patient off of ECMO in an adult in the U.S. We've got a pediatric case on file, and I believe there's some docs over in the EU that are doing very similar to what you just did, working with advanced ECMO patients. And there might be another site in the U.S. that's doing similar, but I think you're the first one we can say actually had brought it in and helped an adult, and particularly a prolonged ECMO case, to be able to bridge off. So I'm really glad that we were able to connect and we were able to get up there and help this patient, and really appreciate the opportunity you gave us and the RTX to actually show its stuff.
Yeah, and it's definitely sparked an interest in our division, in negative pressure ventilation. It's certainly part of the ventilatory curriculum now for our critical care fellows. I'm the program director for the fellowship. And, certainly I think that, when it comes to where we might be able to look for this type of assist, I think this opens up a potential research question, in the ECMO population. I think we can all see the benefit. Again, it does require quite a bit of comfort and transition, since I think all of us are well-versed in the application of positive pressure, but, and because of that comfort level, choose to stay away from things like negative pressure. But I think you go back to, Phil Drinker and the iron lung, and, I'll be probably presenting this case at the Philadelphia Drinker Society, which, I think is very fitting, since it's, named after Phil Drinker and the iron lung. So we'll see. I'll see what some of the other regional critical care programs, think about the use of negative pressure assist.
Wonderful.
All right.
That's great. We wish you best of luck with that presentation. And I can offer you some sympathy with bringing in a new device to an unfamiliar clinical environment. That was my first exposure as well, with a cystic fibrosis patient with a pneumothorax. And it was the first time anybody had seen that in the United States. So it was a difficult thing to do, but I can have sympathy for you and trying to get people to agree with what's going on, but I think you can see the clinical benefit.
Absolutely.
The outcomes are speak for themselves, and it's so great to talk to you about this today. Yeah,
I think comfort and familiarity often comes from I think trying to introduce kind of de novo, I can certainly understand, what it would take to change culture, to bring something in that you might have, tailored application for in in the adult population, say a ventilatory weaning unit or something like that. You know what I mean? But at the same time, I think, in something like prolonged ECMO or ECMO patients in general, when you're trying to wean that last bit of circuit help, I think there's a real research question there. And with protocolized, education around, a particular aim, like a research project, I think you can provide education, increase familiarity and comfort that you probably can't do to try to bring something in de novo to a respiratory care unit that is, been working with positive pressure only their entire career. So, I hope that there's something that we can come up with, for aim and research, specifically in the ECMO population. So we'll see where that goes. And certainly I'll be reaching out to Gary and whatnot if we can come up with something.
That's
Super.
wonderful. Great. If we can be of any assistance, let us know. We certainly advocate for more knowledge and more data, because in God we trust, but everyone else needs data.
Absolutely. Yeah, without a doubt. But yeah, from a safety, efficacy, and comfort standpoint, I was pleasantly surprised. And this is where you got to understand. From my standpoint, this was a young woman who was extremely difficult to control. Her ventilator synchrony, being awake and alert. You can think about the tachypnea, the mechanical power, the stress, the strain that goes on those injured lungs. That was always a major concern for us. And then you think about adding something like this, and is she going to feel any additional strain as we, try to apply negative pressure? And I have to say, she actually looked much more comfortable. And she kept it for 30 days. Unfortunately, she was, chronically critically ill and had succumbed to an unrelated infection. But yeah, she survived on positive pressure with negative pressure assist for almost 30 days.
Well, again, her struggle is over. She's at peace, but we know you did all you could, and thank you for that. And I'm sure the family thanks you as well.
And thank you, because I do think, at the end of the day, we all grew and benefited tremendously from your team and the support that you showed, because it was sort of an email at 1 a.m. Hey guys, can you get me this thing? So I honestly didn't think it was actually going to work. So I'm really grateful for that. But yeah, I think that, and I think for you guys, that was one of the most powerful parts at the end of this journey, even though it wasn't the outcome that we wanted, that the family was given an additional month, and that time was very powerful.
Indeed. Every day is precious.